going to give a talk on anesthesia service in remote areas, my experience.
Samson here, he did his MBBS from JSS Medical College, Mysore from 2001 to 2007. He did his post-graduation diploma in anesthesiology from Father Mullah Medical College, Mangalore from 2009 to 2011, working as freelancing anesthesiologist in Kodegal since 12 years. Life member of ISA IMA. Paper presentation on retrograde intubation in National Conference at AITAA. Over to you.
Thank you, sir. Thank you for the kind introduction. In this, it's private practice and peripheral places. The nuances and the implications, the complications, or the advantages, disadvantages involved in private practice, as well as the thing which happens in peripheral places, I'll be just telling you in coming few minutes. What motivated me to choose anesthesiology? I was working as a duty doctor after completing my MBBS in a charitable hospitals. There I was working with a surgeon. Like, I wanted to do surgery then, but there I came across 2 or 3 anesthesiologists. I was introduced into the field of anesthesia. Though in MBBS I was posted in anesthesiology for internship, that was not taken seriously. In fact, I didn't attend it. Let me be frank, I didn't attend it. But at that time, we did not have any exposure to anesthesiology. So during my tenure as a duty doctor, I was exposed to anesthesiology. I was made to give spinal. I was made to learn intubation while doing anesthesiology I was working as a duty doctor. So that created interest in me to choose anesthesiology, and also I came in acquaintance with a physician and a surgeon there, and they were planning to open a hospital in my place. So I thought it's better to go for anesthesiology. Slightly personal selfishness there. Okay, let's come to advantages of private practice. Yes, choice of place. I've been lucky enough to choose the place of my choice because I'm working in my place itself. Choice of hospital to a certain degree, yes, we can. Yes, I have chosen the choice of hospital. And choice of working hours, sometimes yes, we can, but being in peripheral places, being there as only 1 or 2 anesthesiologists, choice of working hour may not work in our favor. What is the other advantages? More autonomy in professional decision, no hierarchy system. Like, I need not explain anything what I have done to my seniors or professor or HOD. So basically, I can be master of my own. This hierarchy system sometimes delays the services that is required to the patient. I have seen in medical college, there was a patient with PPH. In the discussion what to be done, 1 hour was lost and patient died on the table. This was before I could join anesthesia. This was in a medical college. Whereas the same thing happened in a charitable hospital which I was working in. There, immediate decision was taken. I even now remember the blood group of the patient was same as the blood group of our obstetrician. She went directly into the blood donation room. She donated the blood. Case was taken immediately. It was a profuse bleed. More than 2 to 3 liters of blood was lost. Announcement was made in a church. Many people came down there, and 2 to 3 bottles of blood were taken. Like more than 5-6 bottles of blood, units of blood were taken, and anesthetist was willing to give anesthesia. She was almost on the verge of death. So that patient was saved. So these are the things which can be done if there is no hierarchy system. Within 10 minutes, the patient was on table and she was saved. So coming to challenges in private practice, solo practice, like if something happens, we don't know what to do. Like the help will be little far. And comparatively, we'll have lesser cases, and it's sometimes difficult to refuse cases. You will be busy since morning. You are told to do 1 case now. You cannot refuse cases because the rapport with the surgeon or the non-availability of other anesthetists, you cannot refuse the cases. Sometimes we will be at the mercy of the surgeons. And coming to disadvantage, the no time to academics in day-to-day practice. I won't tell no time to academics. It's just that motivation or the need to learn, or mainly the motivation will not be there. So we'll be busy running from one place to another, calls at odd hours. Sometimes we'll encounter ill-equipped OTs. Ill-equipped OTs, I've seen 2 or 3. Once or twice I've given anesthesia in there. If I stretch my hand, I can touch both walls. So that was the condition of the OT. Right now I'm not going there, and that OT is also stopped now. The next thing is in periphery, the 3 M's matter: the manpower, the machine, and the medicine. Manpower, we don't get enough qualified manpower for us, but we have to train whatever we have got. So here I would like to highlight, I've been training few staff to put LMA, and one of the staff, even I was training to do intubation. He saved a patient. Before I could go to the casualty, he had intubated a patient of OP poisoning with respiratory arrest, and that patient was put on ventilator. He was saved, he was extubated after 2 days. And machine, like, we will not get advanced machines because of the financial constraints. Vaporizer will still, now I am using Tech 3 vaporizer for only halothane. That hospitals are not ready to invest in those things. And monitors and ventilators, ICU ventilators we have 1 or 2, so that is a lifesaver many a times. Medicine, as I mentioned, their problem with narcotic drugs, the excise department, they treat us, we are asking them for a license to sell alcohol. That is what their mentality is. So it's sometimes very difficult to get narcotic drugs. Even ketamine was difficult for us to get at some time. And non-availability of blood products immediately. That again is a difficulty. So once I had to do auto transfusion for a patient with ruptured ectopic with massive bleed. Cannot wait for the patient to be shifted to somewhere. I cannot wait for the blood to come in. So we were, at that time we were getting the blood collection bags. Now it is difficult, we cannot get the blood collection bag. We took the blood from the peritoneal cavity, we got into the blood collection bag and transfused, and patient was saved. So pre-anesthesia communication, yes, most of the time we may have to do it on table. That is mainly with regard to LSS, that emergency LSS. Otherwise, I make it a point that I see the patient prior to going into the operating table, preferably a day priorly, or if it is a sick case, I tell the surgeon, please inform me so that I can counsel them. And documentation, yes, since the day of my starting practice, I've been maintaining diary. Since last 5 years, I am using this Log4 AS app. So that, okay, it's not opening, it's okay. Time is also running out. So I'm using Log4, it's an Android application, so you have to enter few things. After that, you can get many things, like you can enter the incidents happened, and what are the age group of the patient, what's the weight of the patient that is done. So that will help us, like in rural setup, I have anesthetized many pediatric patients, but they may come when they'll tell pediatric anesthetist should give anesthesia only, so others cannot give. So at that time, if I have given, and if something happens, I can show that I have done so many pediatric cases, I have the experience to handle this. So I think sir can tell us that legally can hold good, I think. And recognition, yes, we get a little bit of more recognition in the smaller places, so that people do accept us, because we are lesser in number, we are known to everyone. Sometimes we have to accept the failure with regional anesthesia, and then we have to go into whatever has to be done. Remuneration, I've been lucky enough that my senior is there, so sir will take care of everything, and whatever he tells, every nursing home they give. This is not clear, this is, I just wanted to show you what Log4 is and what can be done. Whatever the incidents that has happened, I have just, I can type it there, and it will be there in the record. For the last 5 years I've been using this. Till this, I have anesthetized around 7,874 patients. I can get the accuracy because I am maintaining the diary as well as the app. And general surgery and OBG accounts to more than 90%. General surgery, we do laparoscopic surgeries also. The other minor, other departments are just minor contribution to my whatever I do. General anesthesia is about 20% of it, and regional anesthesia mainly spinal and a few blocks. general anesthesia, about 10% of the general anesthesia, 30% is for intubation thing. So these are the few complications I encountered in my practice. I'll go it. I wanted to elaborate it, but time is not there, so I'll just go faster. Foot drop following spinal anesthesia. I gave spinal. Next day, the patient did not recover. She had neuronal injury. I thought she had neuronal injury. Then it was a neuronal injury. Then slowly the power was coming back. Then foot drop did not improve. Then they started coming again and again and again and again. After a few days, they are telling, "We will give complaint in the police." We will. I said, "See, this can happen. You go to, if you want to go to police, you can go to police, or if you want to go to court, you can go to court." And then MRI was done. After we suggested MRI very early in the period, but they got it done after nearly a month. It was a disc prolapse corresponding to the foot drop. The L4, L5 disc prolapse was there. That was causing pressure on the nerve roots. That was causing foot drop. So I was kind of saved there. NPP, negative pressure pulmonary edema, 5-year-old for minor surgery. Why I put this was the so-called short GA. It'll take one more minute, sir. So-called short GA can be a problematic thing. It's a 5-year-old child. We did a small excision of a cyst in the chest region. Short GA, like mask holding was done. Patient developed NPPE. Then what to do? We had ventilator, so that was a boon for us. Put the tube in. Explained that to the attenders. Ventilated for maybe 6 hours, then after that it was extubated. Due to time constraint, I'll go further. So for a few years we were doing ICU also, OP poisoning, snake bite with neuroparalysis, hanging with cerebral hypoxia, we were managing that. Right now we are not doing that much of ICU experience because most of the patients are getting shifted to Mysore. Thrombolysis we have stopped now because thrombolysis has gone into oblivion, slowly going to oblivion because of the primary PCI they are doing. Lot of cases we are doing we're doing like acute LVF. Few cases, like one case we did a pacemaker insertion in that place. Right now we are not doing it. And since I worked in surgery, I have inserted many ICDs also. ICD for a pneumothorax that was done around 2 o'clock in the morning. No surgeon was coming, so I had to insert, and that patient was saved. To conclude, safe practice, patient safety, or our safety. Yeah, all three should be there. Safe practice I meant here was, can we take only, because it's a rural setup, can we take only like what we feel safe patient? It cannot be done because ASA1 patient, ASA2 patient complications can happen in them also. So safe practice, yes, we have to do safe practice, not in that sense. Patient safety, yes, it is of paramount importance. And our safety, why I put that is, what prompted me to put that is, last one of the CME, in POCUS CME, they were telling, even for pleural tapping, now ultrasound guided is required. That's the standard operating care. So, we don't know where do we stand. In rural areas, we do a lot of those things. And I think the concerned administration or the people at a higher post in our associations need to have some basic guidelines for like what is done for in PPF for monitoring in our rural setup. Something has to be done. And the minimum standard in anesthesia care, what's more important, man or machine? It's always the man, but machine is also important. We need to upgrade ourselves, although we are in rural setup. The importance of support system, yeah, ISA and IMA. I'd like to quote one incident and like to close my talk. ISA, there are very few members in our place, so IMA is very strong in our place. We had an incident where a patient died. There was vandalism in our hospital. More than 200 people gathered, and they vandalized our hospital gates, and then at that time, within 5 minutes, more than 15 doctors came, including sir. Sir will remember that. So more than 15 doctors came. Even though we could not prevent what they do, but it was a great moral support for us. Being in a rural area, it is very important for us to be associated with one or the other medical bodies. Thank you for patient hearing. Thank you organizers for giving me this opportunity, especially Dinesh sir who called me and encouraged me to present this. Thank you very much.
Thank you. I want to add one more part. Usually.